NCLEX prioritization is a very big topic you have to master. Right. So this is example. And this is aware of several clients. Okay. But what? Who situation need further workup? That means we got to do something, right? Then go with the buzzwords. Divide the question into two. The first portion will tell you what is the situation, and the next one is the problem. This is what is changing, the condition that is changing. Those are the one you focus on. So the first one, we have a 4 hour after AAA repair, abdominal aortic aneurysm. Okay, and so what? Making 330 ml per hour urine for the past 4 hours. You think is okay, you have to be sharp, not an expected finding, right? Is this patient having shock or sepsis? Is making 30 ml every hour. Think about it. A client admitted with what? CHF exacerbation. What is the patient reporting about? Leg edema. Is this patient having airway issue? Or think about it. Patient absolute neutrophil count, ANC, is 200. And you're reporting what? Chills. Is the patient having sepsis? Ask yourself. Patient has diabetes, hemoglobin A1C is that. And you're reporting what? Morning glucose is 200. What do you think? These are the way you should approach the questions. And then if you do that, you see that it becomes easy. So what do you think is going on? And what do you think who we need to see first? That's all. As you can see, based on the content, if you have what? AAA repair, and you pin 30 ml every hour. So in 4 hours, for 4 hours, almost like 20 ml. 120 ml. I think this guy is doing okay. He's making adequate amount of urine, at least 30 ml per hour. Why would you pick it? Because you saw triple A. This should not be your problem. Be sharp. CHF exacerbation. I don't care about it. I care about what? Leg edema. If you have CHF, would I see leg edema? Okay, yes. Ignore it. ANC, absolute neutrophil count. That means you have leukopenia of 200 and you're reporting of what? Chills. This is sepsis. Bad problem. Like I said, be sharp. Hemoglobin A1C is 9 and his morning glucose of 200. I know if your A1C is 9, that means your glucose is not controlled. I can't do anything. If I have 1 second, I can't do anything about this. This takes like 3 months for me to see effect. Therefore, what do you think we should do? Ignore this. So the right patient is that one. This is the way you approach prioritization. You don't have to memorize it. And I know you got it. You don't have to memorize it, but you got to take a look at it carefully and see the approach, and you'll be able to answer this question. So this guy is in trouble. Okay. Same strategy I'm going to use to answer these questions. And if you know the answer, you can type it. But what is the problem? The nurse provide care for several clients. Which client prescription the nurse should question? We have to question the prescription. That means something wrong with it. That's all. That's the buzzword, questioning. Then go with your content. A client with asthma is prescribed with metoprolol for hypertension. Can asthma patient take metoprolol because they have hypertension? A client with what? Latent TB. That means he is PPD positive, right? Is prescribed isoniazid and he's taking atorvastatin for cholesterol. Is this combination acceptable? Client with what? C. diff, who is on chronic omeprazole and is prescribed metronidazole. Is it okay? The client with IBS, dicyclomine is prescribed what? Artificial tears. So these are some another way the NCLEX will give you. They will give you two situations. First, asthma. Patient is prescribed metoprolol for hypertension. Circle it. Don't worry about the way the question is written. Latent TB. I'm taking isoniazid, and now I'm being prescribed atorvastatin. Is it okay? I have C. diff. I'm on chronic omeprazole, and I'm prescribed metronidazole. I have irritable bowel syndrome, giving dicyclomine, and I have artificial tears, also prescribed. Look at the combination, figure out if it's expected, figure out if the combination is expected, and if it's not, then you got to intervene. Think about it. What do you think? Asthma? Can they take metoprolol? Look at your balm. Asthma is safe with the balm. This is beta blocker. Bisoprolol, atenolol, metoprolol is acceptable in asthma patient, so you can use metoprolol for hypertension in asthma. Wrong answer. Don't pick it. Latent TB, we treat it with isoniazid. Isoniazid affects your liver. Atorvastatin affects your liver. This is a problem. C. difficile because you're on chronic PPI. You're going to get C. diff. But what am I doing? Metronidazole is the treatment for C. diff. Don't worry about it. IBS, we give you dicyclomine. Dicyclomine is anticholinergic. You're going to have dry eyes. We give you artificial tears. Acceptable. This is how you approach these kind of questions. And you can see that B is in trouble. Any question, you can see that this is the way I want you to think about it. Prioritization 101. And if you approach it like that, I mean, or you'll be more comfortable when you see questions related to prioritization. So this patient is in trouble. So this is my Q bank. This is where I get some of these questions from. This is the same thing. Which assessment finding require immediate notification of the healthcare provider? That means we got to report it. And then she's caring for a client with what? Tonic-clonic seizure who is taking what? Phenytoin. This is medication you have to know. I've done a lot of pharmacology for nurses, and the 6 medication you should know. This is one of the neuro medication I did. Is for members. If you just subscribe to Adapting Class or join the membership, you get access. But these phenytoin, there's certain side effects you have to know, right? I said be sharp, not unexpected finding. If it's suspected finding, ignore it. If you take phenytoin, do you get horizontal nystagmus? Do you get gingival hyperplasia? Do you get a small purple rash on your chest? Or do you have unsteady gait? Think about it. Concept related question. Even if you don't know side effect of phenytoin, look at each of them and see if you relate to the B sharp. Horizontal nystagmus. Do you see anything in here? It look like some neural problem. Gingival hyperplasia, right? It may be bleeding related issue, but it doesn't mean the patient is in shock. Small purple rash. Do you know what it is? It's a finding. This is not good. Stephen Johnson syndrome. This is sepsis. Unsteady gait is also a neural problem. So you can see if you look, you use a B sharp. If you need more, you check Adapted Class. I have a lot of video on B sharp, and you can see you can break it down, and it look like you can change every question in the form of that. And you can see that I have a sepsis patient. This gingival plasia is not bleeding; it's in shock, but there's a bleeding issue and some kind of infection, but it doesn't trump Small purple rash on the chest. That's Steven Johnson syndrome. That's bad problem. Bad problem. Bad problem. Therefore, this guy is a problem. Okay, so like I said, if you watch adapt and close videos, you can see that this prioritization, you become more comfortable. You don't get trapped. That's the way I call it. Don't get trapped. Okay. And this is caring for several clients. Which client situation need immediate phone call to the PCM? When you see something like that, you say, oh, something is wrong. Then you go back to your content. You said, okay, let me analyze it slowly. I have to be sharp, not expected. Okay, a client, you taking what? Amiodarone, circle it. What is the problem? AST is 250 and the normal is 8 to 33. That means it's elevated. Should it be a problem? A client is taking clopidogrel, is reporting what? Black Tarry stool. Is that a problem? I'm taking enalapril. I have persistent nagging cough. Is that a problem? I take albuterol for asthma and I have tremor after you give it to me. Once again, you have to be sharp. Is there a breathing issue there? Okay, asthma patient, we give him what? Albuterol to treat the asthma. Is reporting what? Tremor. He's not having breathing issue. He's just giving a beta agonist. His heart rate, his tremor, his diaphoretic, all of them goes up. So this is an expected finding. Don't worry about it. And Narapro, well, if you have cough, it's not a good thing, right? We got to change it to you. But it doesn't mean you're having airway issue. This is not angioedema. Clopidogrel, black tarry stool, you bleeding. And amiodarone, your AST is elevated. It's affecting your liver. But if you watch my video, I tell you amiodarone, you got to be P-clone. That means now, number one is pulmonary fibrosis. C is cardiac. L is liver function. O is your eyes. N neuro. E is endocrine. And D is skin. Check my videos. You see, I explained to you amiodarone. The priority is P-cron, is P. Pulmonary fibrosis is your priority. But this patient is just as LFT that is elevated. We ignore it. Clopidogrel is the one that is bleeding. And Nalapro, we may change it to ARB. Asthma patient, this is an expected finding. So C is more dangerous. And you can see the way I approach them, all of them. B is more dangerous, sorry. I approach them the same way, same way. And this is a quick explanation to get you the content. What do you think about this? Which client should be seen first based on the clinical finding? What do you think? Look at it. 4 clients. They came to the emergency room. They all have flu-like symptoms, right? We all have flu, but who should be seen first? Whose situation is the problem? We all have flu. So all these patients have flu. One has a runny nose, arthralgia, and nasal congestion. Is it worrisome to you? One has small purple rash taking allopurinol for what? Gout. I give you the buzzword, right? One has bullseye rash 4 days after hiking trip. And one has received a IM influenza vaccine 3 days ago. Who do you think is more dangerous? You see, I've already shown you how to approach them. Who do you think we should see first? If you know the answer, you can type it. But who do you think we should see in this situation? Who need to be seen first? One is getting just a flu. It's not a problem. 2, small purple rash after taking allopurinol. Allopurinol is a bad problem. Why? Allopurinol is sulfur drug. Sulfur drug, one of the major problem is Stevie Johnson syndrome, or they have photosensitivity. But Stevie Johnson syndrome is number 1, and they present a small purple rash. That is sepsis. Be sharp. This is your answer. Bullseye rash after hiking is Lyme disease. It's not a problem. Intramuscular flu vaccine, you're going to have some fever. Don't worry. If you have a vaccination all the time, you get like flu-like symptoms. That's not a priority. Therefore, this guy is in trouble. And this is our for client who need to be seen first. This is all content, right? Look at it, break down into pieces, figure out who need to be seen. A client with SIDH is reporting leg edema. What do you expect in SIDH? Do you expect them to have leg edema? A patient who is post-op what? Roux-en-Y gastric bypass is prescribed complex carbohydrate. Is that what you should give it the patient? Be sharp, not expected, right? I'm taking spironolactone for hypertension and I have peak T wave on a cardiac monitor. What is the problem with spironolactone and what does the peak T wave means? I'm taking warfarin for DVT. My INR is 2.1. I've given you the concept. Put down your answer. What do you think? Which one you have to see first? Whose situation is worrisome? Like I said, prioritization 101. Analyze them and figure out what is going on. SIDH is because you have too much ADH and you're retaining what? Water. Therefore, you're going to have leg edema. The priority for SIDH is what? Seizures because of hyponatremia. I told you be sharp. If I put sodium 120, yeah, electrolyte problem in the B sharp. That's why you pay attention to that. Gastric bypass, you want to prevent what? Damping syndrome. If you want to prevent damping syndrome, you should what? Avoid simple carbohydrate. That's sugar. Patient is on complex. That's good. Spironolactone increases your potassium. If your potassium increase in your peak T wave, bad problem, bad problem, bad problem. If you take warfarin for DVT, I want your INR to be 2 to 3. It's perfect. Don't worry about it. Therefore, somebody on spironolactone with EKG changes is not good. These questions are not difficult. They require you to like go through each of them. And every time you see prioritization question, don't memorize it. Don't say, oh, I see it somewhere. So they say it's a priority. Oh, somebody said this is a priority. Look at the four things they've given you and analyze it one by one. And this is what? Caring for a client with pulmonary embolism on IV heparin. That means he's getting heparin infusion. The platelet is now 90,000. Content wise, it's too low, right? It's too low. So that's a bleeding problem. This is heparin-induced thrombocytopenia. What would you do? Decrease the heparin, change the IV heparin to enoxaparin, hold the IV heparin for 90 minutes, or anticipate prescription for rovarazobam. This is content related question. What do you think? What do you think you should do in a patient with heparin who platelet is too low? Heparin-induced thrombocytopenia, the major problem is what? Clotting factor. Therefore, if there's a clotting factor, they're going to have thrombosis, going to have stroke instead of bleeding, and that will be a neurological problem. So we want to prevent stroke. The key concept, they should not get any more heparin. So there is no need to decrease the heparin. You see the content. If you recognize that this is hit, this is the concept. That means no more heparin. If I see heparin, I cancel it. If I see heparin changing to enoxaparin, look at it. Zaparin is the same thing as parin. They all have parin. That means they are all heparin. This is also heparin. Hold IV heparin. You already have heparin-induced thrombocytopenia. Therefore, no. This is the test taking strategy I'm showing you how to answer question. I brought to my content. First of all, I know what is I'm being asked, priority, and what is the case. I have PE and I'm receiving IV heparin. My platelet is 90,000. Those are my buzzword. And therefore, the case is talking about heparin-induced thrombocytopenia. That's my content. And I know my bag of content means if I have hit, no more heparin. That's all. And I need to check for DVT, stroke, and other thing. Therefore, if I see heparin here, I cancel you. This is also heparin. I cancel you. This is also heparin. I cancel. You left with this. Even if you don't know what it is, you just have to pick it. Don't be nice. Pick it because you've used your content to eliminate without going for one answer. Do that. Every time they give you, find what is the question is asking. That's the buzzwords. And then find what the case is talking about. Connect the buzzwords and the case together. Come up with your content and know what you should be expecting and look at the answer choice and just knock each one at a time that they are not part of what I'm expecting. Don't be nice because you know heparin, but you may not know this and you say, oh, this is the wrong answer. No, there's three things talking about heparin there. That means all of them is wrong. Okay, so this is your right answer. Which client's situation require immediate intervention? And next cares for several clients. Client with what? He has reflux, right? He's complaining of constipation after what? Sucrafate. He has IBS, complaining of what? Xerostomia after dicyclomia. He has schizophrenia, complaining of what? Drooling after olanzapine. He has stroke, complaining of headache after what? Tenecteplase. This is all content medications you need to know. What do you think? Like I said, I've done about 10 pharmacology videos on pharmacology for nurses, and I picked 6 medication that is very important. All these medications, I talk about them in the neuro and in the GI. So check out that class, you will see it, but some of them are for membership. So if you join the membership, you get it. But this is the way I wanted to approach it. If you know your answer, you can put it down and let me see what you're thinking. But I'm going to show you the key. Reflux, constipation, and sucrafate. This is how you do prioritization. Underline the key buzzwords and then focus on it. IBS, xerostomia, dicyclomia, schizophrenia, drooling, olanzapine, stroke, headache, Tenecteplase. How does it sound in your ear? It should now sound good when you hear it. Like there's some combination that does not sound good. Combination that does not sound good. And those are the ones I want you to focus on. So bring your content. If you have reflux, we give you what? Sucrafate, right? Sucrafate is a cement. It causes constipation. This is off. Out. IBS, you have irritable bowel syndrome. You have constipation alternating with diarrhea. We give you dicyclomine to do that. You're going to have dry mouth, dry eyes, urinary retention. This is dry mouth, expected. Schizophrenia, I'll give you olanzapine. Olanzapine will lead to excessive secretion, right? It's one of the antipsychotics. Drooling is an expected finding. Stroke patient, Tenecteplase is bad. This is atoplast. That means we give you clot busters. This will lead to bleeding. If you're bleeding and you have headache, it means you have stroke again. So this patient is in trouble. If I give you Tenecteplase, you shouldn't have any more headache. That means you're bleeding in your head. So that patient is in bad problem. So watch for that. So this is your right answer. Which client should the nurse attend to first? A nurse prepared to administer prescribed medication to assigned client. So you are in the hospital, you want to give medication. Who are you going to give the medication first? The client should, which one? Digoxin for a client who has CHF and his heart rate is 85, 80, and 63. Colchicine for pericarditis, his blood pressure is 115 to 70. Furosemide for somebody with severe COPD with a CVP of 25. And benztropine for drooling and shuffling gait after clozapine. Who would you attend first? Don't look at the big words, look at the situation, and you have to be sharp. You have 1 second. All of them have a problem. Why has CHF? Eating digoxin. His heart rate is 63. Do you give the medication to him first? Why has pericarditis? His blood pressure is 115 over 70. He need colchicine. You see, I'm not reading the way the question was framed. Now, I'm reading the way I will understand it. Always do that. Rewrite the question. 3. He has severe COPD and his CVP is 25. We need to give him furosemide. Patient is taking clozapine and he's drooling and shuffling gait, and we need to give him what? Benztropine. Who do you think you should administer the medication first? Who does not have time? That is the whole idea. Look at it. CHF patient, digoxin can be given to them, but there's no, I don't tell you this patient is having acute problem. There's nothing there. His heart rate is 63. He can take the digoxin without anything. Pericarditis, his blood pressure is fine. There's no what? Narrow pulse pressure. That means his pressure is fine. So it's okay. I can give him the colchicine. Severe COPD and a CVP of 25, we call it core pulmonale. That means you have bad COPD. Now you have right-sided heart failure. This guy has two problems. He has right-sided heart failure and he has severe COPD. Look at the CVP 25. It's bad. He needs some laces. Furosemide. This guy take clozapine. He's having drooling and shuffling gait. This is side effect of what? Clozapine. This extrapyramidal side effect. Whose symptoms is worse? This is where now you got to prioritize in your head. I have EPS. I have somebody with heart failure with severe COPD, and it's really wet, and he needs some fluid, and he needs some laces to get rid of the fluid. Furosemide. Somebody who has pericarditis, he needs colchicine. His vitals normal. He has adult CHF. His heart rate is fine. You can see that all these are fine except this guy. He has core pulmonale. So these are little ways you can look at it. Clozapine is secondary generation antipsychotic, causes drooling. It's an expected finding. It doesn't mean he's having airway issue. He's having shuffling gait. This is Parkinsonism. When you look EPS, acute dystonia, akathisia, um, Parkinsonism, and tardive dyskinesia. These are all signs and symptoms of EPS. He's not going to die. We've have given him benztropine. He's not NMS. But this guy is having airway issue in addition to bad and CHF. We should see that patient. Which client situation require immediate intervention? Same thing. And next case for several clients. I have ADHD. I'm complaining of what? Palpitation. Once again, always take your time, analyze it. ADHD, I have palpitation. I'm taking methamphetamine. This is one of the medication I talk about in the neuro psych and a neuro video I made on a pharmacology for nurses. CHF is complaining about leg edema. Cirrhosis is complaining about itchiness, severe pruritus. Schizophrenia is reporting about fainting spells after zaprasidone. What do you think? Think about it. Whose situation is not that great? If you have 1 second, do you worry about it? But then I know you got it. You sit back and you said, no, I got this thing. They can't trap me. I get this. They can't trap me. So don't let them trap you. All of them is worrisome. Heart palpitation. Why? Because you're taking methamphetamine, which speed things up. It's a stimulant. Your heart rate goes up. Don't worry about it. Right? CHF. I will have leg edema. I'm not having pulmonary issue. It's not a problem. If you have cirrhosis, your bilirubin goes up. You're going to have itchiness. Don't worry about it. Just like that, you know, for us to be your right answer. Zaprasidone. It causes QT prolongation. In QT prolongation, you have fainting spells. That's bad. You're going to have syncope, and then you're going to have cardiac history. So that one is worrisome. So that's how I. And as you can see, it's the same thing back and forth, back and forth. So this is adapting class. If you're new or hearing my voice, this is adapting class. And I hope you're learning something. You can see how I approach prioritization. Slow, breaking down all the questions, making sure you can see what is going on. And then if you like this, you can join our crash course that is coming up on the May 15 to 25. To register, this is the website to register. You can join us if you're interested. And these are the courses we'll be covering. Okay, so this is what we'll be covering. But these are questions you have to be comfortable to be able to answer. So one more. An SKS for several clients, right? Which client situation require immediate intervention? Client with what? COPD, complain of what? Heart palpitation after beta agonist. Think about it. Schizophrenia, complaining of what? Auditory hallucination. Somebody has Meniere's disease, complaining about what? The room is spinning. Pericarditis, complaining of what? Chest pain, relief by leaning forward. What do you think? This is something I know you know, but think about it. What do you think? Who is in trouble? A COPD patient, if you give them beta agonist, their heart rate will go up. Palpitation is okay. Schizophrenia patient, complain of auditory hallucination, you have to find the content of the hallucination. That's a bad problem. It may be hearing things to kill somebody. Every hallucination in schizophrenia patient, ignore it. Not ignore it in actual sense. Recognize it and then treat it appropriately. But auditory, you have to investigate it and find the content. You have to ask questions. If you have Meniere's disease, you're going to have vertigo. That's what room is spinning. They are not falling down. It's just the room is a vertigo associated with that problem. Pericarditis, well, you're going to have chest pain. That can be relieved by leaning forward. This is what I mean by be sharp, not unexpected finding. Once again, this question highlight how to be sharp and not unexpected. Otherwise, they would trap you. Once again, you have to be sharp, not expected. COPD, heart palpitation, because I give you beta agonist. This is not a shock patient. This patient is not bleeding. Schizophrenia, auditory hallucination is a bad problem. Meniere's disease, room spinning, It's like what you should expect in this patient because he has what? Meniere's disease. If you have pericarditis, well, you're going to have chest pain, and this goes away when you lean forward. So this is the way you should approach this kind of question. And then when you do that, you see that these questions are not that difficult. Okay, so this is what you should pick. This is Adapt NCLEX, and thank you for watching.